Hey everyone, welcome back to The Explainer. Today we're tackling a deeply concerning mystery, one that unfolds in arguably one of the most stressful environments imaginable, the NICU. We're going to unpack the terrifying experience of newborn tremors, and specifically, the jarring contradictions you often find in how they're treated. Based on insights from the Powless law firm, we're looking at this massive disconnect between what doctors tell parents face-to-face and what actually gets written down in a baby's medical chart.
Okay, let's dive into this. We've got a clear roadmap for today. We'll start with the NICU disconnect, then compare jitters versus seizures. After that, we'll look at the phenobarbital red flag, the root causes of neonatal seizures, and wrap up with seeking truth and justice.
So, Section 1, the NICU disconnect. Picture the scene for a second. You're in the quiet, heavily monitored ward of the NICU. Parents are standing over an incubator, completely exhausted, worried sick, and suddenly they notice something just isn't right. They ask the nurse or doctor this exact terrifying question. Why is my baby shaking? Maybe the baby's arm is twitching rhythmically, or they're staring blankly. Now, a lot of times the clinical team responds with a reassuring smile. They brush the trembling off as normal newborn jitters, saying it's just a totally benign part of adjusting to life outside the womb. Naturally, the parents feel a massive wave of relief. But then, they look at the chart. And that illusion of normalcy? It shatters the moment parents realize the nurse is actually administering a heavy-duty medication. As our source points out, calling a symptom harmless jitters while simultaneously treating it with intense drugs, well, that's actually a form of medical gaslighting. It creates this extreme power imbalance. I mean, think about it. Why on earth would a newborn need an intense medication for a quote-unquote normal transition? To really understand that, we need to look at the physiology.
Which brings us to Section 2, jitters versus seizures.
And this brilliantly illustrates the clinical facts you need to distinguish a completely harmless movement from a literal neurological emergency. The physiological divide here is stark. So, newborn jitters, they're usually triggered by a stimulus like a loud noise. Neonatal seizures, though, happen totally spontaneously. But here is the real dividing line, the holding test. If a baby just has the jitters, gently holding their shaking arm stops the movement right away. If it's a seizure, that limb is going to keep jerking right against your hand. Plus, with jitters, there's no eye involvement and vital signs stay perfectly stable. Seizures are a whole different story. They come with staring, eye rolling, and really terrifying autonomic drops, like a plummeting heart rate, which is called bradycardia, or sudden pauses in breathing, known as apnea. They are entirely different events.
And that leads us straight into Section 3, the phenobarbital red flag.
So if a hospital is insisting that a baby just has a mild case of the jitters, we really have to ask why they'd bring out a serious pharmaceutical intervention. Let's talk about the drug in question, phenobarbital. This is a powerful barbiturate. It's a heavy central nervous system depressant, and its main job is to control and suppress active newborn seizures by literally slowing down abnormal electrical surges in the brain. The source is absolutely adamant about this. Doctors do not prescribe phenobarbital for normal newborn fussiness. The side effects are massive. We're talking profound lethargy and respiratory depression, which often means the baby has to be put on a ventilator or CPAP machine. Doctors only take on those kinds of risks if they suspect or outright know that active, dangerous seizures are happening. Now here's where it gets really eye-opening, because this explains a hidden medical reality. Research shows that fewer than 10% of electrographic seizures, meaning those abnormal electrical discharges confirmed by an EEG monitor, actually produce clinical signs you can see with your own eyes. Basically, a baby might be lying completely still, but their brain is experiencing a massive electrical storm. So if your baby is on phenobarbital but you aren't seeing any shaking, the medical team might be privately treating an invisible neurological emergency, all while keeping up a public narrative of everything is perfectly normal with the parents.
Let's pivot over to Section 4, causes of neonatal seizures.
So the crucial point is, why is this emergency happening in the first place? What's triggering this abnormal brain activity? Well, it comes down to the timeline. When a newborn starts having seizures within the first 48 hours of life, that is a massive flashing red flag. Sure, things like genetic disorders or infections can cause seizures, but the source highlights that when they hit in this specific 48-hour window right after birth, it heavily points to an acute traumatic injury that happened back in the delivery room.
And the single most common cause of these immediate neonatal seizures is HIE, which stands for hypoxic ischemic encephalopathy. Basically, that's brain damage caused directly by a lack of oxygen and blood flow. Listen, if a baby is born, rush to the NICU, put under a therapeutic hypothermia cooling protocol to stop further brain cell death, and given phenobarbital, that is definitely not just a case of the jitters. That points directly to a very high-stakes, severe brain injury from oxygen deprivation.
Tragically, as the Paulus law firm notes, this oxygen deprivation is often entirely preventable and usually stems from medical negligence. We're looking at common, preventable delivery room errors here, things like failing to perform a timely C-section when a baby is clearly in distress, or mismanaging and misinterpreting those dangerous heart rate drops on the fetal monitors. Then there's the improper use of the labor-inducing drug Pitocin, which can cause tachysystole. That's excessive contractions that basically cut off the baby's oxygen like a chokehold. It can also be direct physical trauma from the improper use of forceps or vacuums, or just outright ignoring umbilical cord complications. These are specific, negligent acts that link directly to newborn brain damage.
Which brings us to our final segment, Section 5, Seeking Truth and Justice.
So, when a preventable injury like this actually happens, how do hospitals react? Well, when they suspect a mistake was made, defensive tactics often kick in immediately to dodge liability. One really common tactic the source highlights is called creative charting. Instead of writing down the legally heavy word seizure in the medical logs, staff might use benign little descriptors instead. They'll call them spells, or shivering, or cycling movements. They might even document that heavy-duty drug, phenobarbital, as just a mild preventative sedative rather than an active anticonvulsant. On top of that, they might delay ordering a continuous EEG monitor, which essentially ensures there's no definitive, objective proof that seizures were even happening.
Let's move to and see how this builds into a clear action plan for parents who are demanding transparency. Step 1. Trust your gut and write down a detailed timeline of everything you observe. Step 2 is absolutely critical. Secure the complete, unedited medical records before anything conveniently gets lost. That means raw EEG data, fetal strips, NICU medication logs, the whole shebang. Step 3 involves analyzing the objective chemical proof, like cord blood gas results taken right after birth, which can actually prove oxygen deprivation. And finally, Step 4 is consulting a specialized birth injury attorney. Just as an example, under the Indiana Medical Malpractice Act, proving a case means you have to navigate a mandatory review by an independent panel of healthcare providers to actually determine if the standard of care was breached. Which leaves us with this powerful final thought. Medical transparency is a fundamental right for every patient. If a hospital is telling you one thing, saying your kid just has some harmless jitters, but their actions, like pumping them full of heavy CNS depressants like phenobarbital, are telling a completely different story, you really have to ask yourself what vital truth is hiding in those medical records. Getting a grip on these clinical facts is the very first step in advocating for the health, the future, and the rights of the absolute most vulnerable patients in the room. Thank you so much for joining me for this explainer, and as always, stay curious.